morning, everyone. So, my name is Dr. Matt Gunning, and as Neville politely pointed out, I worked on air ambulances quite a few years ago. Now that's a younger Dr. Matt Gunning. But nowadays I'm an anaesthetist. I spend most of my days in hospital, but I'm still very involved and still very keen on what I call trauma anaesthetic care and trauma intensive care, so tactics, or the tips and tricks that you can use to get your severely injured patient from the point of injury all the way through to the ICU alive. Okay, so tactics. And then just by way of a declaration of interest, I also run a company called Prometheus Medical Africa, and we make trauma equipment for the severely injured patient. But I'm a simple guy, and you've probably all seen this. It was told to me just as I started med school, in fact. In order to keep our patients alive and in order to do a good anesthetic, you need to keep air going in and out of the patient and blood going round and around the patient. Okay. You laugh, but that's anesthetics in a nutshell. I'm a simple guy. All I've got to do is deliver oxygen to the tissues, and this is how you do it. Okay. Unfortunately, our patient has got blood going out and not coming back in. And he's got air coming in and getting trapped in the wrong part of the body and not going out. So he's got a double hit, two problems. Okay, so we've all heard about the shift to the CABC, or the military paradigm, the March algorithm. And this is to prioritize catastrophic hemorrhage, to get hemorrhage control so we stop our patients from bleeding out and going into shock and obviously dying. And the crux of the matter is that it's the red blood cells that are delivering the oxygen to the tissues. And like I said, my whole job is to deliver oxygen to the tissues. So we need to keep the red cells inside the body. Okay, and this talk about prehospital hemostatic resuscitation is all about how we keep the red cells inside the body. So we heard earlier that this patient has got a deep laceration to their groin, possibly a femoral artery, and he's bleeding out. If you can press on something, that's compressible hemorrhage, press on it. So we heard exactly right from the community medics, you press on it. And you press on it until it stops bleeding. If that's not working, consider a tourniquet. A little bit controversial in the past, now very much a mainstay of treatment. So if you can get above the wound, apply a tourniquet. Just remember, when you're using a tourniquet, it's going to hurt. You need to pull it tight, and you need to stop arterial flow. So it's going to hurt. But you've got to stop that bleeding. And if you're stopping that bleeding, you're then going to stop perfusion. So you're going to have to start the clock. You need to make a note of the time that you put it on. Unfortunately, you're not always going to be able to get above the wound. So in the case of the groin, you're not going to be able to put a tourniquet. And the classic defense wound in an assault, you're putting your hands up and you get stabbed up in the axilla or into the root of the neck. So you're not going to potentially be able to put a tourniquet there. You're going to have to think about other things. In the neck, you can consider, I'm sure you've heard of the trick of putting in a Foley's, inflating the bulb, just remember to tie it off. Or you can pack the wound with novel hemostatics. So these are gauze that are impregnated with things like Cartazan, and these adsorb the blood and help form the clot. So you pack it in tight, press on it for about 5 minutes, and then put on a tight compression dressing. Okay. So like I said, if you think of the vessels and the vessel wall as a wall itself, okay, if you've got a hole in the wall and you want to fix that hole, you're going to have to fix it with bricks. And I like this analogy. The bricks are the red blood cells. They're being held together with cement, which is fibrinogen and platelets. But without those bricks, those red cells, you're not going to be able to repair that wall. Okay, so you need to keep the patient's own red cells, because those are the only ones that really clot and carry oxygen well inside their own circulating system. Okay. So we heard about occlusive dressing. So the key, like I said, he's got two problems, is going into somewhere it shouldn't be. So if you've got holes in the chest, you've got to go looking for those holes. Make sure that you expose your patient properly. Make sure that you remember that the chest has got a front and a back. So the patient might be lying on their back, but look at their back. It's got sides, and a top and a bottom. And remember those defense wounds that look up into the axilla. But essentially in a spontaneously breathing patient, if they've got a large defect in their chest wall and they're breathing in, they're going to be preferentially sucking air into that potential space, into that pleural space. You need to seal it with an occlusive dressing, so as they breathe in, it seals. It allows air to enter into the lung, re-expand the lung, and expel the fluid out of the dependent areas of that chest seal. once you've sealed up the holes and they're still breathing spontaneously, air can continue to leak into that pleural space if they've got a laceration to the lung, obviously. Okay. And as air enters into that space, it can cause a tension. And tension is going to stop venous return, and that's going to stop the blood going round and around, you've heard this before, and the air going in and out. So as soon as you detect a tension, which you can do clinically, or if you work for a UT ambulance service with an ultrasound, but if you don't, your patient becomes more and more tachypneic, the breath sounds reduce on that side, they become more and more shocked, they're hyperresonant. If you start to detect signs of tension, you need to immediately relieve that tension, which you can do with a needle decompression in a spontaneously breathing patient, and that's going to allow the blood to go round and round and the air to go in and out. Okay. So we're starting to get to the crux of pre-hospital hemostatic resuscitation. Let's make this a little bit more interactive. Who did? You've got your cards, your green and red cards, yes and no. Who did matric biology? We're all healthcare practitioners here. And I've seen lots and lots of green cards, of course. Okay. I never did matric biology. That made first year med school a hell of a difficult, but that's a different story. Okay, so what you're looking here at is wow, lots of drawing all over my slide, strangely. And I'm not sure where that came from. I'm doing that, wow. Get that done. Okay. So essentially, you've got the lethal triad. What is the lethal triad? Okay, it's how you become coagulopathic. So our patient, he's awake, he's talking to us, but he's starting to become anxious and agitated. He's bled a hang of a lot onto the floor. He's cold, he's clammy, and he's starting to become hypovolemic and tachycardic, so he's beginning shocked. He's beginning acidotic, he's getting cold. And if you become acidotic and cold, you're going to become coagulopathic. Why? Matric biology. Clotting factors are actually clotting enzymes, and enzymes work best at a neutral pH and a normal temperature. So if we're exposing our patients and not keeping him warm, in other words, covering him afterwards, he's going to get cold. If he gets cold, he's going to bleed because our clotting factors aren't going to work. And the clotting factors form fibrinogen, which interacts with the platelets. Platelets don't stick if they're cold. So keep your patients warm. So you've heard of damage control resuscitation. So damage control is a naval term. It's the essential steps that the Navy needs to do to get a damaged ship or a vessel back to port for repair. Okay, so what's pre-hospital hemostatic resuscitation or damage control resuscitation? How do we do this in the pre-hospital phase? So I've given you some of the tips already, but this is the most important slide. If you take nothing away, these are the 4 tenets of damage control resuscitation. Number 1, permissive hypertension. Okay, so here we're going to be prioritizing hemostasis over perfusion. Okay, we're not aiming for normal blood pressures in the pre-hospital environment because that's going to pop clots. Okay, so it's not forever, and there are going to be problems with that, but we're not aiming for normal blood pressures. Number 1. Number 2, limit crystalloid. Okay, this is key. So he's already bleeding. He's already consuming his own clotting factors. So it's a consumptive process that's going on. If we then add in a dilutional process, by which I mean we're diluting his red cells and his clotting factors, we're not going to be clotting. And number 2, that saline is going to start to damage the endothelial glycocalyx, or in normal speak, it's going to make the normal vessels start leaking the fluid that's inside. Okay. So some of I mentioned the military. A lot of the militaries now have got something called a walking blood bank. So in other words, you get shot, they take the blood from the guy next to you. Okay. It's fresh, whole blood, and they're giving it to you. Like I said before, your own blood is the blood that carries oxygen best. It clots the best, but it's the next best thing if you need blood. So you don't need crystalloid, you potentially need blood. And there's some really forward-thinking pre-hospital services now that are using packed cells and plasma as opposed to crystalloid. Okay, but number 2, limit the amount of crystalloid that you're giving. Okay, acute coagulopathy of trauma. So we know that severely injured patients who become shocked are going to become coagulopathic because that fibrin, that cement that we were talking about, is starting to break down. So fibrinolysis. Okay. So add into what we've just talked about a dilutional component, a consumptive component, and then make the patient a little bit colder, and you're going to land up in a coagulation sort of situation, a trauma-induced coagulopathy. Okay. So we need to prevent that from happening. and early damage control surgery. So damage control surgery is not definitive surgery, it's surgery that allows the damaged vessel to get, it's all about correcting the physiology, not repairing the injury, if that makes sense, okay? But the key for us today is not the damage control surgery, but the early part. So in other words, we don't delay on scene. We recognize that this patient needs to go in, and they need to go in quickly. Okay. So for our patients, we can consider putting in an IV line, as was mentioned, but we're certainly not going to delay, especially if this patient's shut down in CAMI. If they are, we can consider doing an intraosseous, potentially even doing this en route because it's nice and quick. Okay, but we're certainly not going to talk about turning on the taps before we've tried to put the plug in. That's the wrong way around to fill up a tap. Okay, you've heard that analogy before. Okay, so we can consider putting on an IV, potentially giving them some analgesia, some morphine for the pain, because we said that this is going to hurt, and so is the tourniquet. We need to get going quickly, but before we get going, we need to tell them that we're coming, so don't arrive unannounced. We need to tell them that we think that this patient is potentially going to need urgent surgery, and possibly we even need to trigger the major hemorrhage transfusion protocol. Okay, 10 points. What's this button? The demist. Fantastic. Yeah, someone got it. Okay. So when you give a handover, when you arrive on scene, okay, and when you arrive at the hospital, hopefully not unannounced, you need to give a structured handover. Okay. So you find your trauma team leader, you say, hi, trauma team leader, I've got a lot of information to hand over. So I'm going to give it to you in a structured format. This is one structured format, D, for demographics. We've got a 43-year-old male. Mechanism, he's been stabbed. He's got some stab wounds on his chest. Injuries, we found 2 holes in the chest and a large laceration to the groin. Signs and symptoms, he's showing signs of hypovolemic shock. Okay, he's got a heart rate of 140, his systolic's now 80. He is hypoxic with SATs of 94 despite the face mask oxygen. And in terms of treatment, what we've done is we've put on occlusive dressings on each side of his chest. He showed signs of attention, so we did a needle decompression to the left side, which helped to relieve that. He was bleeding out, so we packed his groin with a novel hemostatic gauze, and we applied a compression dressing. We put up an IV, but we haven't given him any crystalloid. But we do believe that he is bled out, potentially needing urgent surgery, and possibly needing a massive transfusion. You got it? Excellent. Okay, thanks guys.